clinical trial designs, development and design of master protocol, and application of Bayesian methods in modeling in clinical trials. Dr. Saptarshi Chatterjee holds a PhD in mathematical sciences from Northern Illinois University. So today they'll be sharing their experiences from a chronic pain master protocol design. Yeah. And without any delay, I would hand it over to our speakers. And as usual, we'll be on mute as the talk is going on. And for any questions, please use the chat window. We'll have a question answer session towards the end of the presentation and one in between when there is a change in the speakers. Yeah. Thank you. And Dr. Chatterjee, it's all yours.
Yeah, thank you so much, Matangi. Appreciate all the nice introduction, and thank you also for the invitation to speak to this wonderful group this morning. So Phoebe and I, we are privileged to represent Lilly team to share our experiences on chronic pain master protocol. And we have been developing and implementing this huge trial kind of construct with multiple sub-studies. And so this has been going on for over a few years. And we are here to share our experiences as well as some of the context in the participation in the CID pilot program. So throughout the slides, we are going to share some bits and nuggets of innovations, and hopefully you'll be able to see why this was an excellent case in the participation. So here is a brief outline of the talk today. So we are first going to start with some motivation, like where it came, what question that we'd like to answer. And we are then going to deep dive into the design of this chronic pain master protocol, and we're going to share our experiences in the participation in the CID program. Now, chronic pain master protocol, because of its construct, it relies heavily on statistical borrowing, and we are going to spend a little bit of time on the statistical borrowing consideration as well, like different parts of that. And later on, we are going to talk about some of the key learnings and challenges from our experiences in the implementation. So, so just to give a brief idea, like where it all started. So a few years back, we were challenged with this question, like by some thought leaders, like how we can develop a framework or some kind of like a clinical approach where that approach is to quickly evaluate multiple assets in multiple indications or disease types where we don't have any a priori information, like which asset would work better or would worse in the pain indication. So if we don't have any a priori information on that, like how we can develop this framework that can quickly evaluate some of the assets that we had in the portfolio for multiple pain indications. Now, when we are asked with this, so we thought about like two scenarios that we saw in practice, internally or externally. Like in the left, you see a scenario where a molecule is actually like being tried in multiple trials, in multiple POC, in multiple, like for pain type 1, pain type 2, pain type 3, and pain type 4. While that probably answers a lot of questions, but that's probably not very efficient because this is not constructed in a way like where like we can share information internally. So that's the sharing information, or like doing something more efficiently. I think it was not probably an optimal option. As well as like if we go to the right side scenario where we just try only one POC, and because of the budget constraint or because of some other condition, and we just try one molecule in one pain type in a single POC's framework, and at that POC, if that molecule fails, then that molecule was terminated after the single POC, and it was shared. So this is not also optimal. Like, so we are trying to find a little bit of balance between these two scenarios. And this is where we are today to answer that question. So this is the framework at a very high level, like of the chronic pain master protocol. We basically have kind of like a grid structure where in the rows we have the indications: knee osteoarthritis, fracture pain, and diabetes peripheral neuropathic pain. And we have what we call ISAs. that interventions specific appendix for each of these pain type, where we are basically evaluating an asset under this. So you can think of like it's a mixture of like both a platform type of trial as well as the basket trial. Because if you look at the role, like, then if you look at like a particular indication, then we are evaluating multiple assets in that indication. So that's, in that way, it's kind of like a platform construct. Versus like we also have an opportunity to look at like how that asset like behaves or performs across different pain types. So that way it's a little bit of like a basket type of framework there. um, and the way it's we constructed it is, this is like we actually had an overarching protocol to this whole thing, which is the master protocol. But then each pain type is a disease state addendum to that protocol, and each sub-study is an intervention-specific appendix. So we kind of thought it about like from a modular fashion perspective, where again the goal was to find a lean and efficient signal identification if you are challenged, like based on the challenge question that we had, and this structure gives us that, as well as because this is a single construct and there are different sub-studies within that construct, it's much easier to share information if needed. And also there are some efficiencies that we are going to talk in detail later. Now, little bit deep diving into the design, not the design, but like more like a structure. So on the tier one, or at the overarching tier, we have this overarching master protocol, and where we are laying out some of the key things that are applicable to all sub-studies, to all pain types. So something like what is the entry criteria for the master protocol, and like if there is a common, like we had a common randomization schema across all the ISAs. So those were outlined in the master protocol, as well as like what is the hypothesis that we are going to evaluate. So that's common shared hypothesis across all indications and interventions. That was also is going to be documented in the master protocol. And some of the advanced statistical modeling and the operational efficiencies that we have observed. So this is not also specific to a particular asset scenario. Like some in some cases, like to have like a overarching kind of like the statistical model, then this can also go to the master protocol. The whole idea was like to specify as much as the like high level overarching thing in the master protocol itself. And then the disease state addenda was like made for specifying anything that is related to a particular population or a indication where some entry criteria, some inclusion exclusion criteria specific to that disease state was captured in that disease state addendum. And you can think of the ISA as kind of like a document where anything related to the asset that actually went to that ISA in the intervention specific appendix. So anything like the dosing regimen, as well as like the sample size, or any other like the interim analysis consideration. So anything related to specific asset that was kind of documented in the ISA or the intervention specific appendix. So any unique eligibility criteria or assessment, or any unique inclusion exclusion criteria for that particular asset, that would also be captured in the ISA. And looking at the flow, so this is kind of, I was mentioning about the modular fashion. So this is kind of like that modular fashion. Like on top, we have this chronic pain master protocol, which has this common elements there. And under that, we have 3 pain types. And for each pain type, we have a disease state addendum. And within each disease state addendum, then we have these ISAs, or intervention specific appendices. Now, what happened and what we experienced by having this modular fashion is like, of course, for the first ISA, the protocol authoring time and the ISA time, that was of course like a little bit longer than usual for the POC. But the subsequent ISAs got benefited a lot by this, because you can imagine like a lot of these details were already laid out in the master protocol itself and the disease state addendum. And the ISs have just like a lean like a section, like where if there is anything specific to the asset, they have to lay out that portion. So it was meant to be much more efficient and then like from the timeline as well. So it had a great advantage because we kind of constructed in this fashion. Um, so so basically with that, okay, maybe before I go to this part, any question up to this part, maybe up to this slide, any question? Sorry, I cannot see the questions section. So
I'm not seeing anything in the chat yet, Saptarshi.
okay, great, thanks.
Do you want me to take this next part to talk about the design?
Yes, I was expecting that interim slide to come up, but it did not come. So yeah, please.
Oh, okay. All right. My name's Phebe Kemmer, and at this point, I'll talk about the design elements of the chronic pain master protocol. So as it mentions here in this box, our key question was the need to answer more questions more efficiently and in less time. So really the master protocol provides this overarching framework for lean, efficient signal detection. So some of the main considerations were, implying this standard framework, but also maximizing flexibility to meet portfolio needs. The scope of the master protocol is all phase 2A proof of concept. Any phase 2A work is done ahead of time and separately. The design decisions don't need to be constrained by registration requirements because this is all still fairly early phase. But our goal is to maximize transferability to provide information moving into phase 3. Within the master protocol, we kept all our sites to North America, so they're all in the US and 2 in Puerto Rico, just for simplicity. And also we have, as Saptarshi showed, that hierarchy. We have this master protocol structure, and independent of that, we have ISAs within that, but they all build on the master protocol structure. Next slide, please. Did I lose you, Saptarshi?
Sorry, do you see the key features of the master protocol slide or the previous slide?
I don't. I'm still seeing slide 8.
Oh, sorry about that. I thought I moved. Now you see that?
I'm still on slide 8. Anyone else?
Yeah, it's still on slide 8. Perhaps you may want to stop sharing, and maybe Dr. Kemmer can start sharing, if that's okay.
Okay, sure.
Okay, just a sec.
Yes. Yeah.
Okay, is this working?
Mm-hmm.
Yeah.
Okay, sounds good. So some key features of our master protocol design in chronic pain. We have many common scales that we assess no matter what disease type we're studying. And we have 3 disease types of chronic pain in this master protocol. So we always have a pain numeric rating scale. So we'll go over this on the next slide, but our primary objective is our primary efficacy measure is the average pain intensity measured on a 0 to 10 numeric rating scale that's assessed daily. We also ask about worst pain within the past 24 hours. We do a visual analog scale, which is a graphical version where patients make a mark along a continuum, and then that's measured and translated to a 0 to 100 scale. We have, for some of the disease states, we do have some specific disease state pain assessments like WOMAC pain, for instance, for osteoarthritis. We also collect several physical functioning scales, emotional functioning scales, quality of life scales, and the patient global assessment of change that kind of assesses how patients perceive that they're improving over time. And each of these scales sometimes are assessed at different time points. Like some of them, like the average pain intensity measured via the numeric rating scale, is asked on a daily basis. Others are only asked every 2 weeks, and they have various recall periods. And we even assess some sleep outcomes as well. So, the key theme that comes up with master protocol is standardization versus flexibility. So on the standardization side, we have standardized data collection across all of the ISAs, all of the sub-studies of the master protocols, and a similar visits structure. So that can increase our confidence in portfolio level decisions because we have apple-to-apple comparisons. And then we have a master protocol level team, a steering committee that we established to be able to analyze the efficacy analysis data rather than having a separate team for each of the standalone ISAs within the master protocol. We have a master protocol level team, and we've set decision rules to help us make data-driven portfolio level decisions. Okay, the slide advanced on your side, right?
Yeah.
Primary objective and endpoint. Okay, good. So just a little bit more about our primary objective. As I mentioned, we use this average pain intensity measured via the numeric rating scale. So every day, each patient in our trial has a little e-diary. This is a tablet, but it's more like a smartphone device. And every day the patient is asked on a 0 to 10 scale, select a number that best describes your average pain in the past 24 hours. So if it's about osteoarthritis, it asks about pain in the knee, for example. And the patients answer an integer value from 0 to 10. And then they're also asked about their worst pain in the target area. The e-diary device also asks about rescue medication use, things like that. But this is assessed every day during the study. And since this pain intensity scale can be applied towards any type of chronic pain, we have chosen this one as our primary efficacy measure across all of the chronic pain types in the master protocol. So that's our primary measure, and our primary analysis method is the Bayesian mixed models repeated measures model. So as I mentioned, we ask the patients this question every day, and then that can be summarized on a biweekly or weekly basis. This is our basic visit structure across the master protocol. So at visit 1, they signed informed consent and they enter the master protocol. At visit 2, they begin washout of their other pain medications and they start entering their diary data. And between visit 2 to visit 3 is when we get that baseline data to establish their baseline pain severity. And then between visit 3 to visit 7, which is an 8-week period, that is the double-blind treatment period where patients are randomized 2-to-1 LY to placebo, and they're answering that daily diary question every day. And then we tend to summarize this on a weekly basis and look at change from baseline to week 8 in the double-blind treatment period. So each ISA can set their critical success factor separately. It can be done at a master protocol level, or it can be, we have the flexibility to specify that at each ISA if desired. And the CSF has this structure. So the posterior probability that the treatment difference is less than some effective interest. If that probability is greater than some probability threshold, then we can declare success. And the reason this is a less than is because here we're measuring pain reduction. So negative values, a negative treatment difference is good here. So this effective interest can be defined based on the literature. Typically, we've done a Bayesian network meta-analysis based on external data to set that benchmark. And then we do lots of simulation studies to set some probability threshold that gives us confidence in making a decision. So that's all set a priori and specified in the statistical analysis plan for each ISA. Okay, next slide. So I'll just mention within each ISA, and an ISA is just a sub-study of the master protocol, we always randomize patients 2-to-1 active arm to placebo. And the reason we do that, one, we're trying to maintain patient friendliness. So, the lower the chance of being on placebo, typically that benefits the patient. But also this is because placebo borrowing is a big statistical benefit of the master protocol. So, once we've enrolled a few different ISAs, we have more and more placebo data to borrow from. So even though at the beginning, we only have 33% of our patients are on placebo, over time, that placebo arm builds and we're able to borrow the placebo data. We can have some sub-studies overlapping and enrolling patients at the same time. But within each ISA, we always maintain the same 2-to-1 randomization ratio. And each of the ISAs has its own placebo arm. So each sort of operates as its own clinical trial, but we still have the ability to do this borrowing because all the data comes across as a big integrated data set. Okay. So as I mentioned, a big theme of the master protocol design is balancing standardization versus flexibility. So I'll just walk through some of these key points. So on the standardized side, we do choose that same primary endpoint across the master protocol, and that's the average pain intensity measured via the 0 to 10 numeric rating scale, collected via a daily diary. But we still have the flexibility that each ISA can specify the sample size of the trial. They can determine the critical success factor they want to use. They can specify their primary efficacy analysis model and how much they choose to perform treatment effect or placebo borrowing. The standardized side says we always randomize 33% of patients to placebo within each ISA, but we also have the flexibility to include multiple treatment arms for each ISA if that's desired for a certain asset. Each of the ISAs has an 8-week double-blind period, but within that, the amount or the duration of the active treatment period can vary. So if you don't have sufficient toxicology data, for instance, to support a full 8-week treatment period, it could be shorter. The master protocol uses a comment visit schedule. So that visit schedule I showed, where we have a baseline period, visit 2 to visit 3, patients are randomized at visit 3 and then followed for 8 weeks. That's a common visit schedule across the entire master protocol, but each ISA has the flexibility to add additional scales or visits as needed. For example, if we need follow-up visits after the 8-week double-blind period, that's an option. And then we have identical inclusion-exclusion criteria just to kind of maintain as much similarity as possible between the ISAs to allow for borrowing. But in some cases, we have added additional inclusion-exclusion criteria at the ISA level. So it's a balance between these two things. And now to talk about our experience with a complex, innovative design, I'm going to hand it back to Saptarshi.
Thank you so much, Phoebe. Before we go to this section, any question?
Yeah, there is one question on the chat.
Okay.
The question is asking, do you only borrow concurrent placebo data?
So the way in which we borrow, we'll actually get into borrowing a lot more pretty soon. Saptarshi's going to handle that in the statistical consideration section, but that can really be flexible. You can borrow any of the placebo data you've collected thus far, or you can say you only want to borrow placebo data collected from the previous ISA. That can really be flexible. Any other questions for now?
Yeah, I don't see any, so I think we can get moving.
Okay.
Great.
Oh, there is one more, sorry. Yeah,
okay.
Okay, let me read the question for you. Have you all used master protocol for pivotal phase 3 studies?
So this chronic pain master protocol is only being used in the proof of concept stage, early phase 2 studies.
Yeah, thank you.
Mm-hmm.
Okay. Is there any other question in the chat?
Not any as of now. Yeah.
Okay, great. Then we can move on. So no, thank you, Phoebe. Like I mentioned before, we were thankfully accepted to the CID CID plan, this pilot program. So as part of that, we had a couple of face-to-face meetings that had occurred at the FDA, and both meetings went really well. And we overall had a successful interaction, and Lily was satisfied with the overall experience and the interactions with the FDA. And one thing that I think Lily and FDA, both sides, they would agree that these interactions led to a more improved and better overall protocol, and hopefully that would help the patients getting medicine sooner. Can you please go to the next slide, Lily?
Mm-hmm.
So regarding the general timeline, so here we are sharing like generally sort of what we observed as well. So the sponsor submits, like we submitted the CID meeting request, and which we consider at day 0. And then there is a window of 45 days when FDA evaluates the CID meeting request, and around day 45, FDA notifies the sponsor about their status and whether like when they proceed to the disclosing discussions, or otherwise the meeting would be denied. And then there is up to 80 days period where the FDA and sponsor discuss this disclosure elements. And on day 80, then they reach that agreement of the disclosure and the meeting is granted. And 10 days after that, the sponsor submits the CID meeting 1 package. And 30 days from that, then the first meeting happens. And 1 month later, the sponsor again submits based on the interaction that on the feedback that is received on the meeting 1. The sponsor submits another package, and that's for the meeting 2. And then after 3 months from that, then there is this other meeting, which is the second meeting between the FDA and the sponsor. And I think it was highlighted in the CID like the portal that like in case there is no need of doing a second meeting, and in case the sponsor and is satisfied with the first meeting, then they can actually go to the start of a clinical trial based on that discussion. So there is no need in case like this second meeting is not needed. Can we move to the next slide?
Mm-hmm.
Thank you. Sorry, there is a little bit of disconnect at my end. Can you hear me?
Yes, we can hear you.
Okay, great. So overall, we had a very positive experience in the CID, participating in the CID program, especially like a few benefits here that we noted, like this collaborative setting between the FDA and the sponsor that helped us in obtaining technical statistical input from FDA. And some of the discussions at the early stage in the design process that was extremely beneficial, because in this construct we had multiple sub studies within the framework. So having a design discussion pretty early in the design process was extremely helpful. And CID, like the program itself was very much informative in the sense like going forward how FDA and Lilly would actually communicate on the simulations, Bayesian methods, and the results. So it certainly provided us a framework to actually go into like how or how it should be done for the future meetings. And certainly there was this an avenue that was created by the CID pilot program, which enabled similar opportunities for system discussions. So in case like there is a need to do a discussion outside the CID pilot program, then we actually have an avenue created that we can prolongate and we can create outside the CID pilot program as well. And one exciting thing that actually happened during the CID program was like we actually were able to collaborate with FDA competition team on the R Shiny app. So there was an app that Lilly team developed, and there was a nimble and informal dialogue over that, and we handed over that app to FDA so that like all the simulations that we did during the CID interactions that was validated within the app. So this was certainly, I think, very interesting, at least to my knowledge. Now, with all the benefits, I think we also realized that there are some opportunities from improvement, especially like the timeline of the overall progress that we got. Like in our experience, it was close to 10 months. If I think if that can be shortened a little bit, then that would be great. That we felt, as well as the comments that we received before this meeting. I think it was the second meeting where we received the comments of like around 36 hours, and if we could have received that a little bit before, and then like if we could have provided the feedback accordingly, that also would enable us to have a very informed dialogue. That we felt as well as I think we really appreciate the consistency in the meeting attendees between the first and the second CID meeting as well. And in the statistical considerations, I think this framework and the structure of the master protocol and the hierarchy level, that, like the way that it was set up, so it laid out a great framework for doing a statistical borrowing, and also, like, there are a lot of challenges that we faced during the implementation as well. So some of that was around the borrowing, as well as there's one thing called risk enrollers that we also faced during our implementation that we are going to talk about in this section. Next slide, please. So first of all, let's start with the benefits. Now, because of the single protocol and having sub-studies within the protocol, it allows for direct comparisons of assets and within and between pain types. Now, we had an advisory board meeting before starting the master protocol, and we received a comment there that how often do we wish that a drug was in the same protocol and we don't have to rely on the like external borrowing, or like don't have to rely on the non-direct borrowing through a meta-analysis. Now, in our CID interaction as well, like FDA expressed enthusiasm in actually the opportunity to assess and evaluate the relevance of like how relevant it is for one chronic pain state to another chronic pain state, like how related they are, and like seeing that impact in the different borrowing. There was a lot of interest in that. So the one key point in the pain research is this question of like how much pain do we have. It can be answered in many different ways. So we have this NRS scale, numeric rating scale that Phebe mentioned, which is from 0 to 10. We have the VAS scale, which is the continuous scale, which is from 0 to 100. We have frowny face, we have happy face. So there are many different ways that you can capture the similar information. And the question is like, no matter where or how we collect this information, but you probably believe that this information is somewhat related, which also like adds a lot of like fuel into this sharing information piece naturally. And because we had a consistent collection of safety and biomarker data across the master protocol, that was also very helpful to add to the standardized data collection, which was also one of the key things that we thought that we were able to do some integrated analysis because of that consistent collection. And because of the borrowing of the placebo information within the treatment, within the pain type, there was certainly like like if we have multiple assets being studied, and then if we are at the last stage, then because of the accumulated placebo, already our accrued placebo data already up to that point, then there is a way to reduce the sample size in both active and placebo arms, which we also realized in some cases. Next slide, please.
Next slide.
Yeah. Now, thinking of sharing information in the master protocol, it can come from a few different scenarios, or it can come from a few different sources. Now, definitely there is this historical external control, which is definitely not unique to the master protocol, but we can still do that having in the master protocol. So it's not like because we have this master protocol, we can't really borrow from historical control. We can still do that. But in addition to that, we also have two different sources, and one source was used heavily in our implementation so far, which is the borrowing of specific information from the other ISS within a single pain type. So it's kind of like that umbrella or platform level framework that we have within a single indication that sort aids this specific information borrowing from the other ISS. Now, we also have a construct to borrow the treatment effect information for a given asset, but there was always this question like how these pain types are related or not. And although we implemented that a little bit, but not to the extent where we implemented the placebo borrowing. And typically that information could have been borrowed from both ongoing and the completed ISS in case the patients have the opportunity to complete the placebo control portion period. So it doesn't have, we don't need that like an ISA to get completed before we can borrow, because there's a way that can be set up and that can be done as well in the master protocol. Next slide, please. Now, some of the consideration that we had for each ISA is now one question that we frequently get, that once we have a historical or a previous ISA, or maybe another DSA is complete, like then how much placebo or treatment information that we should borrow, how much is good, how much is bad, and we frequently get this question, as well as there are a lot of ways and approaches that we can use and employ to borrow, whether we can just pull the data, that means the full borrowing, whether we do some sort of like a Bayesian hierarchical model, or the commensurate prior, where we are going to look at the commensurability between the ISS and it's going to borrow more when the ISS are more commensurate, or the mixture prior, where we feel like the outcomes are more of like an exchangeable in some cases. And so some of these methods we have, but I think there is no clear consensus a lot of the time, like which method is more interpretable, which method we should use at what time, like when we have one ISA, two ISA, three ISA in the historical subset, then what method actually is better, as well as like there are a lot of questions also on the part that during the time, because the master protocol can run for a long time. Now over the time, the placebo response might change. Like the patients might expect like to get a drug over the time, or the expectation to get a drug over time might change, as well as the response to getting a drug might also change because this protocol is running for a long time. And because of that, if there is a placebo response, if there is a drift in the placebo response, then how we should handle that or incorporate that may also impact the placebo borrowing. And the big question on the treatment effect borrowing is like, how do we think the treatment effects are related between the pain types? Now, one challenge that we face, and we are probably going to talk about that a little bit next in the later part as well, like because these mechanisms are kind of novel, so there was no a priori knowledge like how the treatment effects would be related between the pain types within a particular asset. Now, how do we think that's going to play out, and what's our notion of like having a success or failure in one or two pain types, so that it changes our expectation of success in a third pain type? So there are some questions that we faced, and there are some questions linger around the borrowing consideration that I think for each ISA that we try to think about it, and we kind of somewhat tackled a few questions, but not all the questions. But yeah. Okay. Now, in the placebo borrowing, this is probably a little bit less controversial of a topic, because we all understand the benefit of leveraging the placebo data from historical ISS to analyze the current ISS. Now, what are the benefits of placebo borrowing? Definitely, it has potential to improve operating characteristics, such as like if we look at some statistical properties such as power, these are all frequentist properties, and some of the properties are, like we see advantages if we plan to do placebo borrowing. Now, what are the operational conditions that actually allow for placebo borrowing? Now, because of the master protocol, we went to the similar sites. We have a lot of similar scales. And in fact, if you look at each pain type, we have actually the same scales. So like these multiple candidate drugs are studied in the similar population. If the inclusion criteria are not too different, then we are looking at the similar population, and we are studying multiple candidate drugs. So you probably would think that this is the best scenario that we can ever have to do a placebo borrowing CPMP. Now, that can also have some, or that can also aid the exchangeability of the statistical consideration. That means there is no a priori ranking in the patient population that we know across these different assets. If this population is very much generic there. So in the statistical exchangeability, we have this standardized data collection, we have the pain scales, we have the similar randomization. So that means that the patient's expectation is also quite similar, as well as the disease structures also are the same. So these all kind of sort of set the path to do borrowing and then have the construct aid in the borrowing. And we also have the same investigative size across analysis. So because of these similarities and because of these advantages, then the statistical exchangeability is in place, that which probably improves our confidence in the statistical borrowing. But there are some caveats. there are some challenges. Like, for example, what happens if the historical placebo data is not 100% commensurate with the current data? And if there is some sort of like a mismatch, this kind of goes back to the question of a prior data conflict, and what we are going to do with that. And if we have dissimilar data, and if we have only one historical placebo data, and we have the current data, and if they don't match properly, and if we feel that baseline characteristics are pretty similar, because of the master protocol and because of not two different criteria, then what better reflects the truth about the drug, whether this is the current data or the historical data. Now, if we think of like there could be some operational considerations, such as like if we have different routes of administration, because these endpoints are all subjective endpoints. So these different routes of administrations could have different expectation that can impact some of this borrowability, and also like the historical data and the current data sets. What we have seen in the pain research that sometimes also shifts a little bit. That we can also think about, like whether borrowing is the best thing to do in these cases, like whether the confidence what we see in the current data versus what we saw in the historical data, whether that that sort of like certainly differs systematically, and how to account for that systematically. So that there are some questions on that, as well as like what we observe sometimes, like if the data looks very similar, then the natural tendency is to borrow that data, versus when the data looks very different, the natural tendency is not to borrow that data. But sometimes by doing that, we are kind of incorporating or we are injecting the human subjectivity there, and it's probably very critical to plan this for this scenario before actually accessing the data. Now, one good thing about some of these borrowing methods that we discussed so far. Sorry, can you hear me? I saw some disconnect message at my end.
Yes, we can hear you now.
Okay, great. Thanks.
There was a break of about 3 seconds.
Okay, sorry about that. Sorry, I have a little bit of patchy connection today. So some of these methods that we briefly discussed, that some of these are dynamic enough or adaptive enough to actually automatically decide how strongly we should borrow. And this is often done by comparing the historical outcomes to the current outcomes. And sometimes, like if it's possible, we can also try to match the baseline covariates first to make sure that like systematically there is no differences in the population, and then we are looking at the similar cohort. And then if we can do the dynamic borrowing on top of that, I think that aids that confidence, or that gives the confidence that we are looking at a very similar population first. Next slide, please. Yeah, thank you. So in the borrowing approaches, so there are many different ways, and there are many different methods available in the literature how borrowing could happen. And borrowing can happen not only on the control arm, but it can also happen in the treatment arms as well. Some of the borrowing methods are static, meaning like there are basically a priority determination of how much borrowing it is going to do, whether it's going to be the full borrowing, such as pooling, or like it's done to the power prior. It can be pre-specified how much of the information that we'd like to share or borrow. But some of the methods could be dynamic, such as the Bayesian hierarchical model, or the mixture prior, or the commensurate prior. Now, the big advantage of doing a dynamic borrowing is it borrows more when the current data is similar to the historical data, which is a big reason of doing that, because it protects us against the over borrowing. We certainly don't want to borrow the information that is very dissimilar if like given the baseline characteristics are kind of similar. And so we don't necessarily need to follow like whether we should apply or whether we should look at one single approach for all types of borrowing. We can have like a static case in case it feels like these ISS are starting at around the same time. We have a concurrent ISS scenario. If we feel that the patients are going to be very similar, then we can actually go with the pooling option. Like, but in some cases, it probably feels more reasonable to actually consider the dynamic borrowing. So it doesn't have to be really the same method. Next slide, please. Now, when we're talking about the dynamic borrowing, what it is actually, and I know like there were previously quite a few lectures on this, so I'm going to be very brief. So there are two extremes. One extreme is there is absolutely no borrowing, where the primary analysis is only going to rely on the current study data. And there is another extreme where the placebo data would be pulled from other ISAs for the primary analysis. So that like we are literally saying like we're treating the other ISAs or historical ISAs as if they are kind of coming from the same study. There's no differentiation at all. So that like we are kind of utilizing all data that is available, and which is kind of straightforward. And in some cases that also is appropriate. But in cases where we are not very sure that whether it is possible that there could be some cases, or there could be some situations like where this like historical cohort and the current cohort could be a little bit dissimilar, then it's probably that it's good to choose the dynamic borrowing, because then we are kind of borrowing the placebo data only based on the similarity to the current study, meaning like we are not really considering like anything that we observed in the historical ISS can come from the current study. We are kind of saying like a part of the historical data actually part of the current study, but not all. And the dynamic borrowing automatically adapts to how much to borrow. So that adaptivity is there, which kind of protects us against the over borrowing. Now, in CID discussions, when we discussed these approaches, I think FDA, what we found is very supportive of this approach. And in implementation wise, we kind of expect the properties of the dynamic borrowing to fall between the extremes of no borrowing and full borrowing. Definitely, in some cases, we are going to see advantages in full borrowing, but that is only under certain assumptions. And we observe that when we deviate from the assumptions, then we see some increased bias with the full borrowing. Excuse me. Although it reduces the standard error all the time, because we are essentially using more data in the full borrowing. But with hierarchical borrowing, it's somewhat in between, because in cases where the data is similar, then we approach the full borrowing versus not. So, and then when we kind of average out the scenarios, we kind of expect like the properties that we observe that is always going to fall between these two extremes of no borrowing and full borrowing. So that's where the dynamic borrowing really lands, and that's the expectation. And when we did the simulations, that we actually observed that the dynamic borrowing can actually control the type-1 error, and without really impacting or without really hurting us on the type-1 error, it can actually increase the study power under certain conditions, of course. Okay. Next slide, please. Now, a little bit of deep dive into the Bayesian hierarchical model here, and this is not really in the context of CPMP, but it's a little bit in generic sense. Like, let's say there are two ISAs. For one ISA, we have two arms, placebo and asset 1, and then in the other ISA, we have asset 2, but we have two arms there, asset 2 dose 1 and dose 2, and we have the placebo cohort. So what we are doing the dynamic borrowing is we are essentially like looking at so we are like the model of dynamic borrowing is basically constructed based on a hierarchical model where there is this hierarchical prior on the mean placebo effect. So here, imagine like placebo k is the mean of the ISA k, and we have alpha k is the mean of the ISA k, and we have alpha 1 and alpha 2 for two ISAs. So there is this grand distribution that kind of controls like how close alpha 1 and alpha 2 should be. So this tau parameter actually controls that. So this is the key parameter in the Bayesian hierarchical model that kind of can be between a range, which kind of like at the end dictates like how much borrowing actually it happens. And for the other part, we don't need to put any informative prior. So the only informative prior that we have is in this part with the mean placebo effect. For the LY arm, it's just the same alpha here, but then there is a treatment effect. So this is sort of the high-level construct of the Bayesian hierarchical borrowing. And so if we look at the impact of tau, sorry, there is a typo here, it should be tau. And if we look at the impact of the tau now, and at one extreme, when the tau is very large, then basically it means like we have very large variance, or we are kind of very flexible in that two placebo means. So that kind of corresponds to us doing some sort of like a separate analysis without any borrowing. And if we look at very small tau, if we restrict that to be very, very small, that means like it would be analogous to pooling, because then alpha 1 and alpha 2 would be very, very close intact. So that's where that tau parameter is kind of a key piece, and then we kind of put another hierarchy on the tau parameter itself. And we usually give uniform 0-10, so uniform distribution is the distribution that we typically do. So if we look at the choice of the tau, then we see that the borrowing actually depends on the value of tau, and then the dynamic borrowing is like where, if in case there is a discrepancy between the ISS, then more weight goes towards larger tau versus, and like when there is an agreement, then more weight goes to the smaller tau. Okay. Now, we wanted to understand the dynamicness of some of these methods. So we chose here one example of with the Bayesian hierarchical modeling. Now, what we are looking at here is in the x-axis, we have the raw placebo estimate, which is not without any borrowing. And on the y-axis, we have the model-based placebo estimate, which is after borrowing or not. So what we are doing here is two options. One is without any borrow, then we expect the raw data and the model-based placebo estimate would be very similar, that would fall in the diagonal line. But if we do borrow, then we expect that the placebo estimate is going to get deviated. But how much it is deviated from the diagonal line, that probably tells us like how much of what's the impact of the borrowing. And also we are trying to look at the shape that, like, even though it gets somewhat deviated, but if it's truly dynamic, then we expect that after kind of, if it goes further, then it kind of should track back the diagonal line, because the dynamic borrowing actually should be a little bit adaptive to that, so that like if there's too many differences, then you should not borrow too much. Then it kind of should go to the similar properties as like the similar like estimates as with the no borrowing. And we kind of observe some of that here in this case. Now there are 4 plots, of course, and we have ISA2, means like there are only 2 ISS here, and we are looking at ISA2 here, and there are 6 ISS here. It's in a hypothetical scenario, and we are looking at ISA number 6 here. And there are 2 different choices of priors just to see like what's the impact. Now, of course, like with a different prior on the tau parameter, that we see like there are some differences, like if we look at the top panel versus the bottom panel, but the differences is not as huge as what like dictates us to change or consider like a different prior, of course. But of course, the choices of the prior has been determined by some sort of calibration. But what we try to understand as the key point from this plot is like this really illustrates the dynamic nature, and it kind of tells us like what dynamic borrowing does in terms of the placebo estimates itself, like how we expect that to behave in the long run if we have like a data that is not really tracking with the prior, then what dynamic borrowing does. So this picture kind of gets that. And I think if we go to the next slide, this is where we have a similar idea, but like here in the x-axis we have the observed placebo response, which is similar from the previous one, but in the y-axis we have the standard error of the treatment difference, just to see the impact not on the placebo estimate itself, but also in the treatment difference. And we are not really looking at the mean treatment difference; we are looking at the standard error, just to see like whether the precision in the decision making, whether it changes with the borrowing or not. Now, in this situation, we considered multiple simulations, and we looked at that like the -2 is the placebo response that we considered like coming from like for all ISS, but of course it's a assumption of the truth. Then there would be some observed placebo response that would deviate from -2. And what we try to see is like how the dynamic borrowing behaves in contrast to the separate and the pooling. Now the black dots represent where the separate borrowing or like no borrowing standard error falls, and this pooling is concentrated at the bottom. The reason is like pooling always, of course, like borrows a lot of like all the data so that it has more information. So the standard error of the treatment difference in each of these cases would be much smaller. That's what we expect within the separate and the pooling. But what's interesting is like when we observe somewhat similar of a placebo response close to -2, then we see a touchdown of this prior with the Bayesian hierarchical model. Now, of course, like if we choose a different prior, such as the green one with the uniform, we see somewhat like a little bit like flatter U shape. So the point here is like there is a way to kind of control the trajectory, like how sensitive it should be, how often, or at what point you should put the threshold, like where it should go back to the separate analysis. But this is certainly doable within the simulation, and to confirm like what's the prior that we should consider to achieve certain properties. Okay. So before starting the longitudinal implementation, any questions so far?
Yeah, if there are any questions, please use the chat box. I don't see any as of now.
Okay, great. Then we can move ahead and then answer the questions near the end of the presentation. So what we so far saw is kind of the non-longitudinal piece of hierarchical model where there was no time component. But here we are collecting the data, and we are collecting the data every day, right? So we have this e-diary where we are getting or collecting this average pain intensity over the last 24 hours. So we wanted to utilize all the data, and one way to utilize all the data is through longitudinal model. Now, when we understood the properties and the benefits of the dynamic borrowing, then how it could play out in the longitudinal setup. So here is the framework that we utilized to do that. So we considered a multivariate normal distribution, where the design part of that multivariate normal distribution is coming from the placebo part, where we have this design matrix corresponding to the placebo. Now we have ISS specific K index here, and as well as we have alpha parameter to show that this is kind of corresponds to the placebo. And we have the treatment effect. So this is what this part contributes to. And this is with the baseline covariate adjustment. Now, with the placebo borrowing, all the actions, all the informative priority is actually placed on the placebo part. So we have K and T. T stands for the time point. So we have this model doing the placebo borrowing for each time point, so that like we have the hierarchy on the placebo part, where we have a normal distribution, where we kind of like put a grand mean, but the grand mean it's specific to each time point. So that's where the T index is stating here. And here also we have a precision corresponding to each time point. Now, once we set up that, then a diffuse prior is put on the mu t, the grand mean, and this part is actually quite important, because depending on the h tau, if it's too small versus too large, I think there's a little bit of impact that we could see. But this is where the hierarchy is kind of placed. If you could go with the thing, yeah, another slide. Next slide, please. Okay, thanks. So here is the error part of this large, like this multivariate construct, and basically we have all the all ISS data here. So that's where we basically have a kind of like a long vector with all ISS and with all time points. And we have a block diagonal matrix, which where we'd like to put some prior on that, and we certainly use the diffuse prior. But there are quite a few choices on like how we'd like to model this marginal error variance covariance. Remember, like this is an MMRM model, and in the MMRM, please note that there is no random effect part. So all the error is kind of modeled through the marginal error variance covariance. Now, this marginal variance covariance actually can be decomposed into the few parts. This is sort of the for each ISA, what's the marginal standard deviation, and then there is the correlation part, which can be decomposed using the velocity factor. So there was so we took a separation strategy where we placed some prior on the marginal standard deviation piece, which is the uniform 0 and sigma. And for the correlation matrix part, we used an LKG prior with this shape, and we used the shape parameter as 1 here. But there are a few other options, like if we would like to construct something like an AR1 structure, because the LKG structure with this, like this is going to place an unstructured variance covariance matrix, where we are not going to assume anything on each of the parameters. So it's very flexible. But in case of a convergence issue, then we can actually go to the AR1 structure, or if you feel like we don't really need this many parameters for the variance covariance, and if we feel like there is a homoscedasticness that we'd like to model, then that can be achieved with the identical matrix construct as well. Next step is. So just to give a brief summary, so these are the specifications of each of these model, hierarchical, independent, or pooled. The hierarchical model actually it does dynamic borrowing. With the independent model, we have this we actually are not implementing any borrowing, and with the pooled option, we are actually borrowing all the data that we have corresponding to each time point. So these are the three models that we sort of considered when we have more than 2 historical ISs. We also considered the mixture prior when we had only 1 historical ISA, because we could not really rely on the grand mean estimation if we have too few of an ISA. So we kind of looked at kind of like a mixture prior in that scenario when we have only 1 historical ISA. But for 2 and more historical ISAs, we looked at hierarchical, and these are the models that we considered just for the benchmark. One question that came out of this exercise is the other functions they wanted to, and also we wanted to empirically measure that how much borrowing this hierarchical model is actually doing. Where like there are a lot of literature available. Like I think most of the literature probably go towards the effective sample size or local information. I forgot the exact term, but like there are some other ways to measure the strength of the borrowing of the hierarchical model. Like one approach that we took is to compare the results of the hierarchical model against 2 benchmark models, and the 2 benchmark model is the independent and the pooled. We considered three metrics. One is the mean shift ratio, and the variance shift ratio, and the precision ratio. So one of our colleague, Albert Mann, so he kind of developed this metrics to kind of quantify some of the borrowing. And the concept of the mean shift ratio is like how much of the shift in the location that we are actually experiencing with the hierarchical borrowing as compared to the pooling, and that is related to the no borrowing. So if you look at the denominator, that is kind of coming from the pooled model and the no borrowing model, the independent model, and the numerator is kind of coming from the hierarchical and the independent model. Whereas the variance shift ratio is the similar idea, but instead of the mean placebo estimate, we are looking at the scale or the variance, and the precision ratio is quantifying the contribution of the grand mean to the contribution of the variances of the grand mean to the contribution of the posterior variances after doing the hierarchical borrowing. So those are the 3 metrics that we kind of used to quantify how much of the borrowing that's actually happening after implementing these models for a single data set. Now here's an example result for a single time point. So what we see here, like the placebo group, we see that there is some shift in the location as well as the scale, like the credible interval gets shortened usually after doing the borrowing. And also the location also changes. And you see that change in the placebo group, but you don't see the change in the treatment group. The reason is here we only focusing on the placebo borrowing. Now, if we look at, and in this particular example, the mean shift ratio is 0.726, because what we see is like after after we implement full, like if we do the full borrowing, then going from red, we are going to the blue section. So the location is going from this location to this location in the mean section. And the variance is also getting shorter. Like if you look at the critical interval, the variance is getting shorter. Now, how much of the variance and the mean shift in the hierarchical model, which is in the middle, relative to the shift in the full borrowing, that's what this mean shift ratio and the variance shift ratio is quantifying. And what we observed is 72.6% and 63.1% of borrowing that is happening according to this borrowing matrix. And while we could observe the impact of the mean shift and the variance shift through this graphical display, but we couldn't really see or observe like the precision ratio in this way, but we observed something like 69.3. So the conclusion was, with this hierarchical borrowing, we are borrowing up about 63 to 73% according to this borrowing matrix. And lastly, one of our colleagues, Will Landau, developed a package, Historical Borrow Long, which is published on CRAN, and it implements this hierarchical, independent, and also the pooled models. Now, this package uses the stand code using the R packages, RSTAN and RSTAN tools. And typically, when we start with some sort of like some project like this, which is a little bit longer and broad, like we typically start with the JAGs, but we could not really use JAGs or Nimble because they cannot really handle the multivariate nature, or like when you have some kind of correlation within a single patient, that cannot be handled within JAGs and Nimble. So here, in this case, the data model for each patient is multivariate normal, and it also had partial missingness in that, and so we had to rely on STAN for that purpose. And because of the custom hierarchical priors and the unstructured covariance matrices, some of the high-level packages that we have for feeding the MMRM that also could not be used, like such as MCMC Claim and RSTAN ARM. And if you are interested in the non-longitudinal version of these models, there is also a package called Historical Borrow that's also available in CRAN. And in case if you are interested in some of these packages, or if you have any questions, then please go to the GitHub discussion section, which is outlined here in the URL below. Okay, with this, I'm going to hand it back to Phebe for sharing the operational learnings and challenges from chronic pain master protocol.
Thanks, Saptarshi. Any questions on that section before we jump into the key learnings? Okay. If not, I'd like to share some of the learnings we've had since we actually started implementing this chronic pain master protocol about 2.5 years ago, and some of the challenges we've faced. So first of all, just a quick update where we're at now. Our master protocol began enrolling in May 2020, and all of this information you can find on clinicaltrials.gov. We currently have 9 ISAs or sub-studies that have completed or are ongoing. And they're conducted at more than 30 clinical sites across the US and Puerto Rico. And we've enrolled over 1,000 patients in the program. And, you know, there's a lot of startup to get a master protocol started, but by the time we got to the 3rd asset, we've realized many operational efficiencies, including cost reductions compared to standalone trials, a reduction in the time from design lock to first patient dose, and also reductions in the enrollment durations. So that's all pretty exciting. So far, we have disclosed the results from our first asset, and this is on clinicaltrials.gov. So what I'm sharing here is our average change from baseline to our week 8 endpoint. And as a reminder, our primary efficacy measure is this average pain intensity on the numeric rating scale. So this is all on a 0 to 10 scale. And here we're showing just the patient's mean reduction from baseline. So these studies, the first asset, all the studies end in 01. So OA01 is our osteoarthritis study, BP01 is our chronic low back pain study, and NP01 is our diabetic peripheral neuropathic pain study. So as you can see in OA01, our treatment difference, red is the active arm, blue is placebo. Our treatment difference is fairly close to 0. For back pain, the pain reduction in placebo was actually higher than in LY. But for neuropathic pain, diabetic peripheral neuropathic pain, we actually saw the active arm perform better than placebo, as shown here. The delta is just the difference between the active and placebo arms. And I'm showing the sample sizes on the bottom to show you most of these studies are around 125 patients or so. And as a reminder, we're enrolling 2 to 1. So only 33% of our patients are on placebo. So far, we have only publicly disclosed results from our first asset. So based on the data we have available to share with you, we cannot show any results from placebo borrowing because we do placebo borrowing within a pain type, and we haven't disclosed those results yet. But we are able to do some treatment effect borrowing. So within this asset, we can do some treatment effect borrowing. And this is an analysis Saptarshi performed. So actually, Saptarshi, would you like to share these results?
Sure. Yes. So the intent was to see the impact of the treatment effect borrowing on this particular case. So we used 3 different priors. One with the hierarchical Bayesian method, or with the uniform 0 and 5 on the precision. Sorry, on the standard deviation. Another one was the hierarchical uniform 0-1, and another one is the inverse gamma 1-1. While we expect inverse gamma 1-1 to be a little bit like conservative in terms of the borrowing, the uniform 0-5 and uniform 0-1 are expected to shift, or like to have a little bit more of an impact. So overall, what we observed is definitely, like, if you can see, like, the borrowing shrinks the estimated treatment effect in some direction. So for example, for DPNP, where we observed a modest efficacy after doing the borrowing, it kind of pulled back towards like little bit like lesser efficacy. The reason is the associated data that we had with the osteoarthritis and peripheral pain. We did not observe much of an efficacy there. So that's where it was pulled. Similarly for peripheral pain, where we did not see any efficacy, a little bit like a negative result. Then that's where we saw with the borrowing, it kind of shifts a little bit gradually towards like positive efficacy there a little bit. And another thing that we observed with this treatment with borrowing is like, and that is observable much more in the osteoarthritis, is, of course, it's a little bit of controversial topic whether we should borrow versus not. But one thing that we can all understand, like what happens after the borrowing, if you can see as an impact, like the decision making definitely improves. The reason is if you look at the osteoarthritis cohort, and the red line represents the no borrowing versus the all other options, like with the hierarchical borrowing, that represents the borrowing. And you can see a little bit of reduction in the credible interval. Sorry, my connection got disconnected. So specifically, it was observable much more in the option with the hierarchical borrowing with uniform 0 and 1. So you can compare the red line versus the blue line, and that's where you see the credible interval gets shrunk a little bit, which kind of tells the standard error also is going to get reduced, and that improves the decision. So whatever decision that we're going to make out of it, that gets improved a little bit. So that's another finding that we got with this treatment with borrowing.
Yeah, thanks, Saptarshi. Yeah, and as Saptarshi mentioned, the treatment effect borrowing has been a little controversial because, you know, it's possible that a asset could be positive in one pain type and not another. They're not all interchangeable, which is why we do studies in different pain types. But it's an interesting analysis nonetheless. So I'll just walk us through some of our key learnings since we have had 2.5 years of implementing this chronic pain master protocol so far. Some of the benefits are we have the same clinical sites. So, you know, it's a lot of work getting the sites all trained and ready from the get-go. But then after that, you know, you just keep going with the master protocol. Sometimes when a new asset is introduced, there's some new information to share. But overall, once they're trained at the master level, subsequent training is much less down the road. We have the same monitoring team, and we have a single database across the entire master protocol, which yields benefits in terms of site data and site readiness efficiencies. We also have the ability to integrate safety data across the chronic pain states. So for example, for that first asset, we've tested it in 3 pain states. So now we have safety data across 3 pain types that we can use to better understand the safety profile. And we've also collected lots of biomarker information that we can use for various exploratory analyses. Some of the challenges are that we do have a more heterogeneous phase 3-like population, because remember, we want to make this as standardized as possible. So we have perhaps more general inclusion-exclusion criteria than we would have if we were doing standalone studies. This does help increase enrollment speed, but overall, we have fairly small sample sizes for our trials, which could potentially decrease your magnitude of treatment effect. Let's see, we also, as I mentioned, we have 2-to-1 randomization of active arm to placebo. So that's great later on when we have more placebo data to borrow, but for the first asset, we only have 33% of our patients on placebo to compare to, unless we go back later and retroactively placebo borrow from ISAs that complete later. And because we're randomizing 33% of our patients to placebo, that could have some contribution to patients' expectation bias. If they know they have a higher chance of being randomized to an active arm, that could potentially, that's something that plays a big role in pain trials in particular. And then also, because we're following this kind of standardized master protocol framework, we have a limited ability to address asset-specific needs and make adjustments post-data, because it would require a master protocol amendment in some cases. So, flexibility is a little bit limited here. Some other challenges we faced in practice is that it's great that we have one integrated data set, but this does introduce a lot of blinding considerations that we need to take into account. So for example, when one of the sub-studies reaches the end and we want to lock that data set and unblind it, we get all of the data together. So that can include data that we can be unblinded to, and also data that needs to remain blinded because of the ongoing study. So we do actually have an external unblinded statistical analysis team that helps us parse out the parts of the data that can be unblinded versus need to remain blinded. So that's just kind of some extra steps that go along the way every time we do a data transfer. There is the ability to borrow data from the ongoing studies for placebo borrowing, for instance. That can be done, but you just have to be very careful with your blinding considerations and documentation and maintaining a firewall with anyone who becomes unblinded. There are some study differences. For example, one of the assets was administered via an IV infusion, whereas others were oral doses. So it's important to take things like that into account when you're considering your ability to placebo borrow. Another big thing that's come up is repeat enrollers. So part of the design of the study is that if a patient completes one of the ISAs and waits at least 30 days, they can enroll in another one. So an osteoarthritis patient can enter the study for the first asset, complete that, wait 30 days, then enter for the second asset potentially. So we have been seeing some patients doing that. And we need to think about, is that introducing any potential bias? And there's also concerns about, maintaining, or you want to avoid overly homogeneous patient population. So we are considering limiting the repeat enrollers in the future. And then you also have to think about how repeat enrollers could impact your ability to placebo borrow. And then another thing that's come up is not everyone loves statistical borrowing. We have a lot of people who look at our data and make decisions, and some people give more weight to the borrowing results. Some people want to give more weight to the non-borrowing results. So that's something we have to take into account and try to come to alignment beforehand if possible. So in summary, development of the master protocol wasn't easy. It's this big, giant project, but it's a really cool project to work on. And we have realized tremendous benefits, especially in terms of operational efficiencies and ability to do borrowing. And we've learned a lot, which will improve the process of developing more master protocols in the future. As I mentioned, or as you've seen, especially from Saptarshi's part of the presentation, there have been many statistical challenges and problems to work on, and many borrowing decisions we can make in terms of placebo borrowing, treatment effect borrowing, all of that. The consistent data collection in the master protocol should enable better decision-making in the drug development process. It really helps that we have this standardized data collection and we're collecting data from all the same scales. So it makes it really an apples to apples comparison. And then ultimately, the goal of the master protocol is to enable better medicines to get to patients sooner to help improve their lives for patients suffering from chronic pain. So hopefully we will be able to do that. I'd just like to acknowledge, I'm probably even missing some people here, but it really takes a village or more than a village to run something like a master protocol. It's a huge study. So this includes people who are involved in the design, involved in clinical operations. And as you can see, we have a huge stats team and even others outside of our core group who provide statistical support. So I'd like to acknowledge all those people. And that's it. We have time for some questions, I hope.
Yeah, thank you, Dr. Kemmer and Dr. Chatterjee. We do have time for questions.
Okay.
Anyone having a question, you can unmute yourself or you can use the chat option. Yeah, any questions?
I have a question. This is Cora Allen Savietta from Berry Consultants. And I was wondering how you thought about sharing placebo information in the context of different delivery of the different assets. So you mentioned that one of them was, I think, an IV, is that correct? And the others were maybe
right.
orally administered. I was wondering if you could talk a little bit more about that.
Yeah, so one of the things we've done is, the first asset was the one that was assessed via IV infusion. And then the two assets to follow that have been assessed orally. So we've kind of been keeping an eye on the placebo data we've been observing. At this point, we're treating the placebo borrowing analyses as exploratory. So we've been doing those analyses, but just kind of keeping that in mind. And we've also been comparing the observed placebo response to what we might expect based on a Bayesian network meta-analysis of data curated from the literature. So, if a placebo response is higher or lower than what we might expect from that, we have some idea of whether we think it's appropriate to borrow. And we're also considering establishing some test of exchangeability, to see if we think the placebo data is compatible for borrowing.
Yeah.
But yeah, it's all still a bit exploratory. We haven't committed to any one method at the moment, but we're moving in that direction. Anything else, Saptarshi?
Yeah, I'd just like to add to that is like, in case we have quite a few historical studies, not only one or two, then probably you can also adjust for this effect, or it's not only have to be with the different routes of administration, but any systematic effect that we see coming out of this historical analysis, you can probably try to adjust that through covariate adjustment as well. And what we expect that at the residual level, that could be a little bit more homogeneous or exchangeable if we try to adjust for those through baseline covariates. But I think if you have only one or two historical analyses, then probably the ISA itself would have enough parameters that like we don't need that adjustment. So we can treat something like what Phebe mentioned, like just to treat that as another ISA which could have a different outcome.
Absolutely. That makes a lot of sense. Thank you so much. And thanks for this great talk. This was really relevant to our interests. We do a lot of platform trials and master protocols. So thanks so much for this talk.
Thank you so much.
Thank you for your question.
Any other questions? Yeah, I don't see any on the chat as of now. All right.
And our contact info, I think our emails are on the intro slide. So if people come up with questions later, you can always contact us that way.
Yeah, that's very nice, Dr. Kemmer. So if there are no more questions, thank you all for joining the session today. Thanks for a great talk by Dr. Chatterjee and Dr. Kemmer. And we'll see you all at the next KOL series lecture. Take care and have a great weekend.
Thank you.
Thank you.
Bye.
Thank you.
Bye.
Bye.